Hello everybody, I'm Dr. Meenakshi and welcome back to Dr. Meenakshi Academics. In this video, I'm going to be discussing an important topic, that is endometrial hyperplasia with atypia, and this is very important for both MRCOG part 2 as well as for part 3. So there are two different lines of management for this, and it mainly depends upon the fertility intent of the woman, whether the woman is willing to have any further options for fertility or whether she has no plans to conceive. And whenever there is endometrial hyperplasia with atypia, for the evaluation it is important that you'll have to be doing an MRI pelvis as well as even the tumor markers, because there is a high chance that there could be coexistent endometrial cancer and also an ovarian tumor. So it is very important that you'll have to be doing a prior evaluation before you can embark on the management. And then if the woman is not wishing to conceive, directly she will be posted for a total abdominal hysterectomy. And if it is in the postmenopausal age group, then we can remove the ovaries, whereas to conserve the ovaries in the premenopausal age group, that decision would be taken by the multidisciplinary team. And then if the woman wishes to retain her fertility, if she is planning to conceive, right, in that cases we've got different options. Irrespective of whatever it is, always the first option has to be a hysterectomy. But if she is willing to have a fertility intent, then in such cases it is important that you'll have to be going for the next line of management, which is the progesterone maintained based management, as in to reverse the hyperplasia. But the woman has to understand the underlying risk of the endometrial cancer, and if she's willing to take up that risk, then in such cases, yes, you can offer the Mirena coil, which is going to be the first line, or secondly, you can also go for the oral progesterone. And whenever she is on these conservative management, it is important that you have to do the endometrial biopsy once in every 3 months to see whether there is any response or not. And it is important that you will have to get at least 2 negative consecutive samples for us to understand whether the treatment is working or not. And then later on, we'll be doing the 6 to 12 monthly biopsies until a hysterectomy is performed to that patient. So this follow-up is something that you need to be explaining to the patient. And whenever she wants to embark on the pregnancy, it is important that at least 1 endometrial sample should be negative before she can plan her pregnancy plans. So therefore, in the multidisciplinary team, it is important that you'll have to be involving the fertility specialist as well. Subscribe.